Okay, here's the algorithm, and if I can see it. Okay, first of all, you see you have the primary care practitioner, and then they're performing the surveillance every time the child comes in for the child care visit. Okay, if there's anything going on with the surveillance, then the parent has a concern, the practitioner finds that they have a concern, then they would administer a screening tool. If the child passes the screening tool, then they just kind of go on back with the ongoing surveillance. Okay, if the child does not pass the screening tool, then the practitioner may decide that they want to see the child maybe a month or two later on down the line. Sometimes when you administer a screening tool, especially if you're doing some observation, then you may not have a cooperative child. I mean, there's sometimes when I'm seeing a child and the child is shivering in the corner the whole time and uncooperative, and you really don't get a sense of where the child is developmentally. So you see that child back again to see what's going on, and hopefully the child is in a better state of mind, feeling better, more interactive. If there are concerns where the child is cooperative, you feel the child is being totally cooperative, but they're having a difficult, but they may have developmental problems, and you would make a referral to someone like me, a developmental pediatrician, possibly a neurologist, a geneticist. And then you're doing this again, like the whole surveillance, every time they come in, you're doing the formal developmental screening, and the formal developmental screening, even if there are no developmental concerns, you're doing it definitely at 9, 18, and 30 months. I know there is an issue with the 30 month is that generally you're seeing the child at 24 months and not 30 months. So some may do the developmental screening at 24 months. Some may decide to do it at 36 months, really depending upon what's going on with that particular child. But that 30 month is kind of a little bit of an issue. Did I do something? Okay, all right. Okay. Okay, so the child has the developmental evaluations, the medical evaluations, whatever is appropriate. Then the practitioner who is doing the developmental evaluations may give a diagnosis, say for instance autism, and that person would refer that child to the appropriate intervention professionals in the community, and hopefully follow that child over time to give those parents anticipatory guidance, assess how that child is progressing, and again, anticipatory guidance, evaluation, referral, again, and all, and communicate hopefully back to the primary care physician as to what is going on with that child and what the diagnosis is and what kind of things that they can do with that parent or that family as they continue to follow that family. Okay, next time. Okay. These are the components of basically surveillance. So when the child is coming in for the well child care visits, then every time the child is being seen, the practitioner hopefully is eliciting any kind of parental concerns. Now, this varies from parent to parent. There are some parents who will come in with a whole list of concerns, and there are some parents, despite the fact that their child has significant developmental problems, they will tell you everything is okay. So, this is where, I guess you might say the clinical judgment comes in, where you decide whether or not you actually should be doing a formal screening on this child. Documenting and maintaining a developmental history, making observation of the child, especially early on, symmetry of movements, any visual auditory awareness, any kind of social appropriate interaction. If the child, try to see if you can elicit some language or some semblance of vocal interchange with the child. You're identifying any risk factors. You're looking at the prenatal history, the neonatal history to see if the child, say for instance, the child was a 23-weeker, then obviously, and that child is much more at risk than a child who was a 40-weeker who was AGA and had no major medical problems. Any poor feeding, any weight gain. Anytime I see an infant, full-term, preemie, whatever, if they have poor feeding, I have real concerns about that child. More so a full-term infant who had no major medical problems. I really am going to have concerns about that child from a developmental standpoint, and that child, as far as I'm concerned, is pretty high risk. Looking for any kind of dysmorphology, in that child. You're looking at any kind of family history. Is there a family history of developmental problems, family history of autism, mental retardation, learning disabilities, and you're looking at the social history, any kind of abuse and neglect going on. Those kinds of things can really, really affect a child's development. Any hint of domestic violence, and I'm not just talking about physical domestic violence, I'm talking about the whole circle of violence where you have emotional abuse, even if the child is not directly involved in that. If the child is witnessing these kinds of things, the mother is inappropriately talking to the father is inappropriately talking to the mother, those kinds of things are really not good for children's development. And you're maintaining any kind of accurate record and documentation of whatever you found, so the next time that you see the child, you have a sense of the kinds of things that have been happening or going on with that particular child. Next slide. So basically, when you're doing this ongoing surveillance, you're determining whether or not you need to engage in screening of that child. There's some children that you might say, okay, I don't think I need to do a formal screening, I just need to go on and refer this child because it's very obvious. I mean, there's some developmental disabilities that are just so obvious that you know you have to refer the child for an evaluation, a diagnosis, and later on community services. You're supporting healthy development, and I say modeling. Modeling because, you know, there are some parents, I mean, when you're talking about 17 and 18-year-old and young parents that you're modeling in terms of appropriate interaction with that infant during the course of that visit because they may not have a sense of that. And you're talking with them, the parental education, you're talking with them about age-appropriate expectations for that child. I find that this is, a lot of times I think this probably is a huge part of general pediatrics. When I was a fellow, I hate to say this, but it's true, I used to moonlight, okay, at Kaiser. And what I would find is that, okay, I'm treating the pneumonia, I'm looking at the ears and treating the ear infection, but after all that is said and done, the parents' major concerns were developmental concerns. And so you engage in a lot of, I mean, this is a huge opportunity to engage in anticipatory guidance and providing the parents with education related to just normal child development and appropriate expectations of a child during the course of a general pediatric visit. And you're also monitoring the effects of early intervention in the therapy that the child is receiving. Child is receiving speech therapy, then you want to get a sense, okay, is this doing any good? If the child is getting occupational physical therapy, you want to have a sense, is this doing any good? And the parents will, a lot of times will say, oh, he's getting occupational therapy once a week and I think he needs occupational 3 times a week. Or he's getting speech therapy once a week and I think he needs speech therapy 3 or 4 times a week. And that may not necessarily be the case. I find this a lot of times in parents who have children with autism where they're feeling like the child should have more therapy in a certain area and it's not necessarily the most appropriate therapy. So if you feel comfortable doing that, then do that. If you don't feel comfortable monitoring and recommending what might be the therapies for the child, it would be good to consult with the consultant that you had, say like the developmental pediatrician or the neurologist, whoever you consulted about that, about the therapeutic interventions.